Thank you, Dr. Paramartha. Whenever you focus and try to see something with a visual technology, you will always come up with surprises. It was a gallery of vast, diverted clinico-echocardiographic pictures, and I'm sure all of us come across situations like this, and echo go a long way in evaluating and giving the proper guideline as to what should be the treatment and what should be the final diagnosis. Now, Shaumitro and others, my co-chairs, if there is any questions we may ask, because we are running short of time probably.
Yeah, Dr. Paramartha, fantastic showing. Your collection is really good. Just a simple short question. In an ER, what do you prefer, a NT-proBNP, stat, or a echo? Emergency room, patient is coming with shortness of breath. So as per your choice, is it an NT-proBNP, which you will prefer, or a echo? Because echo, you all know, where there are technical issues because we don't have enough manpower to do echo at ER. So what should be the preferred option?
I have worked with you, Dr. Pandey, and you know very well in our setup, doing an NT-proBNP is very difficult. We had an NT-proBNP kit with us for quite some time, and it was my personal experience that we had a number of kits to get a report right from the machine. And talk about, let's not talk about whether the report is right or wrong. We have an echo machine at our setup, and so I prefer to go for an echo for a poor man's early NT-proBNP level is very difficult for us to get.
Opinion of other chairpersons. Yeah.
Arindam, a patient, if he's an old patient, he may have raised NT-proBNP. If he is in atrial fibrillation with high ventricular rate, NT-proBNP may be raised. These are the two very important factors where NT-proBNP is raised despite having normal cardiac functions. So most of the patients presenting with atrial fibrillation, high tachycardia, NT-proBNP may not be the right answer.
Arindam, I think agree with you, sir. Yeah, I think Arindam, these are not mutually exclusive. But if you really insist on having one, I will have the echo, because with NT-proBNP, you might include the diagnosis of heart failure. But you know, heart failure with reduced ejection and preserved ejection have got absolutely North Pole and South Pole type of management difference. So you need to immediately know what you are dealing with. Number two, this elderly hypertensive lady with fast AF and with shortness of breath, you need to see if there is something else, ischemia going on. That is also what is the reason for the heart failure. NT-proBNP will tell you whether it is heart failure or not, but echo will give you such a host of other information regarding type of heart failure, cause of heart failure, prognosis of heart failure. I think you really cannot do away without echo in a case of shortness of breath. That is my humble suggestion.
Sir, if I'm allowed to add,
yeah, please.
If I'm allowed to add, when this ARNI came in, I had a scope of doing the ARNI in some of my patients, of my private patients. So what I found there was NT-proBNP still was raised in some cases who had not developed shortness of breath. The patient had a dilated cardiomyopathy or a case of ischemic cardiomyopathy. The patient was decongested well, the patient is working well, but still at that time with even quite amount of, not maybe it's 200 milligram of 5-MATA they were getting, but still they had a high NT-proBNP with a normal looking,
But Paramartha, in stage A and stage B of heart failure, this is a common practice nowadays to do a NT-proBNP. Even if in a completely asymptomatic patient with no sign of heart failure, you are supposed to do an NT-proBNP in stage B heart failure patient. You know what stage B heart failure by SCC. There is no symptom, no sign. But there you are going to do NT-proBNP because that will put the patient in a bad prognostic category. And you have to be aggressive in those patients, even when there is only LVH or only left atrial enlargement without any symptom or sign of heart failure. That is of stage B heart failure. So its importance is somewhere else, not in an acutely ill shortness of breath patient with doing away with echocardiogram. It is definitely
Dr. Shantanu. Yeah.
Dr.
Shantanu Sengupta.
Yes, Dr. Sengupta.
Yeah. I think it's an interesting question, but I think remember that both the things complement each other. but I will like to give a scientific reason. There is something called BNP deficiency syndrome. So 30% of times of HFpEF patients will have a low BNP. So I think if you give me choice, I would like to do both. But echo gives a lot of information what exactly we are doing it in acute setting, and BNP or anti-proBNP has caveats. 30% of the times you may get falsely high or falsely low, like in obese patients, atrial fibrillation. Things are different. A clinical suspicion and an echo score. So if you have a choice, I will first go for an echo and then anti-proBNP.
I agree with all the expert panel. Only issue is we don't have enough manpower who can do echocardiography at the emergency.
I think
So
we have
Arindam, echocardiography cannot have any replacement, honestly speaking.
Arindam is right. We try to get at least workable echo in all emergencies. That should be our aim.
Particularly a patient presenting with shortness of breath, echo goes a long way in giving a lot of important information. And so far as anti-proBNP is concerned, even ischemic heart disease, acute coronary syndrome may have raised anti-proBNP.
Just to have a quick echo assessment, you don't need an expertise. Even an RMO or an emergency officer can just put the echo probe, and immediately within 5 seconds, he gets the necessary information. What is the ejection fraction, size of the artery, is there a gross valve problem? We don't need any sophisticated parameter for that. If there is a pericardial effusion, within 5 seconds, you get 90% of the information you want. I think we should make it, try to press on the authorities to make echo more available. At least a hand-on quick echo in the emergency. It makes a lot of difference, really.
Fully agree.
So if there is no other comments, I think we are on time. And let me thank both the speakers and the panelists headed by our senior chair, Dr. Anjanlal Datta, to make this session a very interesting academic session. Not only academic, but very clinically useful session. So over to Anita.
So with this, we come to the end of this session. Thank you, chairpersons. Thank you, the speakers. And now we'll take a short break and resume shortly. So our next session is the symposium, The Right Heart Conundrum. The speakers are Dr. Shantanu Sengupta from Sengupta Hospital and Research Institute, Nagpur, and Dr. Ishita Mojumdar from Department of Cardiology, IPJMER and SSKM Hospital, Kolkata. She's also a visiting consultant at AMRI, Salt Lake, Kolkata. May I now please welcome the chairpersons of this session, Dr. D.P. Sinha, Dr. Shourangshu Chatterjee, and Dr. Mahesh Chaudhary. Over to the chairpersons.
Good afternoon to everybody. Am I audible?
Yes, sir.
Could you please switch on your cameras and start the session? Thank you.
So we have a very important session of right heart conundrum. We have two important speakers, none other than Dr. Shantanu Sengupta, to start the session. I would request Dr. Sengupta to start his deliberations, please.